Good afternoon, everyone. This is a topic which is very important for all of us. Very few cardiac conditions we can prevent. And if we can prevent a heart block, we've saved morbidity of about 50, 60 years in a particular patient. There's been a lot of development in this area. And my focus is not to talk about how to assess mechanical PR interval, but about how we can prevent and get contemporary management for our patients. So just a quick call. How many of us do mechanical PR interval assessments for prevention of heart disease, of heart block in this room? And you believe that it is preventing, right? Okay. So 2 to 4% of mothers with anti-Ro SSA Sjogren syndrome will have a complete heart block. We are aware of this, that it is a low incidence. If they've had a previous child with heart block, the number goes up to 25%. So the antibodies we need to look at are Ro and La, SSA or SSB. SSA is the most common, but it could also be SSA and SSB both. But SSB alone has very rarely also been reported. And this is something to keep in mind. If both have not been done, please get the testing for both done. Right. So complete or third degree AV block is irreversible. I think that is something we all are aware of. Anecdotal reports have suggested that if you are at second degree heart block, you give IVIG, you give steroids, you can prevent third degree heart block. How many times we have been in that situation with weekly fetal echoes? Almost none. This cannot be a presumed system of working. We need a better system whereby we can anticipate and prevent it. This is the question which was answered by the two researching groups, one in Canada and one in New York. And one has to work on the earliest detection of abnormalities in the conduction system. So is weekly fetal echo enough? Unfortunately, there is literature which says weekly or even bi-weekly fetal echo surveillance has only rarely detected AV block third degree in time for treatment to be successful. So we are dealing and practicing a modality which does not prevent. You will witness it happening in front of you, but you will not prevent it. I will show you the two articles and talk about them as we go through. One explanation for this is, and it is now also a known fact, that the changeover from no heart block, no rhythm abnormality to emergent rhythm abnormality and finally third heart block, this whole change happens in 24 hours. So if you're seeing a patient 3 days apart or 7 days apart, you're going to miss the heart block completely. You're just going to witness it happen and then tell the family it's now happened. What can I do? Such a rapid transition would only be luckily identified, would not be identified by weekly fetal echocardiograms. There are two large prior studies of routine monitoring in these at-risk pregnancies by employing weekly echocardiographic surveillance, and they both failed to demonstrate a benefit of in-office monitoring. The PRIDE trial we all are aware of, and the second one was by Krishnan et al. Both the studies with 1,000 patients or more failed to show. So where are we? Then came the idea in 2016 of emergent complete AV block. The period of highest risk for development of complete AV block is 18 to 25 weeks. We know this. Anti-inflammatory treatment during the transition period from normal fetal heart rhythm to complete AV block may arrest the progression. So we need treatment in between this. We need to wedge it. So we need to detect something before complete AV block. This transition period between sinus rhythm and complete AV block is emergent complete AV block. This is a term we all need to get familiar with because this is the term we will be working on. It is the time when AV block is developing but not yet emerged. Emergent AV block is characterized by irregular rhythm. If you're following a lupus mother and you see irregular rhythm, you are looking at within 24 or 48 hours possible evolution to complete AV block. It may be a sign of first degree, second degree, or evolving third degree, and it may be a sign of supraventricular ectopics, which may be an indication of the evolution happening in front of you. As the transition from normal sinus rhythm to emergent AV block and from emergent AV block to complete AV block happens in less than 24 hours. The recommended weekly or even other weekly echocardiogram surveillance will not detect. So What next? The researchers in the two groups were looking at how can we detect it. They were trying to prevent it. So they came up with this idea, what if we do it every day? You can't call the patient every day. So they started a modality of heart sounds at home. In 2017, the first publication came. This was from Canada, then US, and then Europe. 3 articles between 2017, 18, and 20. Heart sounds at home, feasibility of ambulatory fetal heart rhythm surveillance program for anti-SSA positive pregnancies. So what did they do? They took a handheld Doppler available on Amazon, does not require PNDT, by the way, and costs 2,500 rupees. They taught the mothers how to look at the fetal heart rate and differentiate it from their own heart sound, their own arterial sounds. And from 16 weeks onwards, they did a daily twice monitoring. First study did twice a day monitoring until 26 weeks because they saw heart block at 25 weeks also. And fetal heart rate was also surveyed bi-weekly by echocardiogram mechanical PR interval. And when irregularity was noted on the handheld monitor, then the patient was called over for assessment of mechanical PR interval. So in 2020, 3 publications were available which said that this was the weekly method of assessment is not adequate and home assessment became adequate. So the protocol was, as is mentioned here, home monitoring. They detected 7.5% of the mothers, irregular rhythms. They called them back. They were also worried that are they causing anxiety in mothers? So the questionnaire actually showed that the mothers were very confident. The results of home monitoring, they were able to pick it up earlier. They were able to give medicines earlier, steroids earlier, prevent heart blocks, etc. They obviously picked up some false positives, which they cross-checked on fetal echocardiogram. We've been following our lupus mothers. We have 90 mothers whom we have followed over a long period of time. This data of 90 mothers is of last 7 years. And we were referred, and I will go through how evolution took place in our practice also. Pregnancies were referred for management of lupus-related issues. So a lady gets pregnant, she's already known lupus because of her previous child or because of her because of her Sjogren's related renal disease or skin disease, or they were referred for mechanical PR interval monitoring because the gynecologist or obstetrician rather felt so, or they were referred for first time rhythm abnormality or heart block. They don't know it is lupus or not, and we evaluate them for lupus. And our total analysis went back to 7 years. So the categories in which patients were referred for mechanical PR interval, known lupus, suspicion of rhythm abnormality, and we say we want to evaluate for lupus. Third was referred as a complete heart block. So we got babies who have heart block now, and they say, oh, this looks like lupus. Maybe can you please now decide what to do? And referred for previous child with heart block. So gestational age at referral, early referral, where they knew it is lupus. They send the mother at 14, 15 weeks, and then we counsel them and start at 15 or 16 weeks, weekly screening. That was till 2020. Primary gravidas referred for rhythm issues at 18, 22. Nobody knows they have lupus. Nobody routinely tests these in all pregnancies. So when there is a rhythm issue, then you wonder, is it lupus or not? And then you investigate. 24, 26 weeks referred for complete heart block, and 28 weeks referral for hydrops or management of complete heart block. These are the groups we saw the patients in. And a weekly mechanical PR interval was done in our patients till 2020, and 16 to 24 weeks till 2020. This was the protocol. In 2020, after analysis of publications and speaking with the two groups, we decided we will introduce daily monitoring of fetal heart rate by the mother. And we started training mothers in home monitoring. Obviously, these are lupus mothers, and recording and sending it to us. It turned out to be relatively easy. And for some reason, whatever reason, Indian mothers, they took onto it very easily, found no problem. In fact, they wouldn't stop at 25 weeks. They say, no, this is something good. I feel very confident with it. I want to do it daily anyways. And we introduced this from 18 weeks onwards because it was difficult to train them at 16, 17 weeks. It was difficult to pick it up. So from 18 weeks, we have been doing this. This is the kind of audio they would send us. I hope I can get the audio to you. No, I can't get the audio. So they would record it. It would be a very good audio. And then it became very easy. And they would do it twice a day and send it to us. What are we watching for on this audio? We're watching for an irregular beat or heart rate which is not regular, repeated beats, or even bradycardia. And if we find any of these, we call the mother over, do a fetal echo monitoring, rhythm analyzed, sometimes daily consecutive basis, and mechanical PR interval prolongation, we start them on steroids. So, which mothers refuse to get on this protocol or could not get on this protocol due to distance in travel and inability to comply with the protocol, and mainly due to remote living? And they were offered two options. You take steroids for the duration from 18 weeks onwards, or if you don't want to do that, you do carry a small risk of having a baby with heart block. And if you're okay with that risk, that's what we will do. So this also included mothers who couldn't even come for the follow-ups for fetal echo regularly. So mothers who were referred for mechanical PR, total of 65 mothers, all complied with the protocol except 6 mothers who could not do it. Of the 65, 56 were monitored from 15, 16 weeks onwards. 7 patients presented between 18 to 20 weeks. 2 patients presented after 20 weeks. 62 were more than 1 gravida and were known lupus. 3 were known lupus and were primary gravida. That means they had other lupus diseases and they got pregnant also. Now, mothers referred with heart block. 25 mothers were referred with heart block. 21 patients had complete heart block. 4 patients had second-degree heart block. 4 patients had hydrops when they presented, and 1 was twin pregnancy, dichorionic, diamniotic. 1 baby had a heart block. The other baby did not have a heart block. And the one with the heart, they delivered at 28 weeks, and the one who was at 28 weeks with heart block did not survive.
Sorry, can we?
Yes. Just conclude. Okay. Hydrops in complete. Yeah, it's almost one slide more, I think. Hydrops in complete heart block, 4 patients during this monitoring, and of the 4 hydrops, 2 hydrops reversed on initiation of steroids, and etiology was anticipated to be myocarditis and which was evident on endocardial fibrinolysis. Hydrops was not because of the rate. They had a relatively better rate and still were hydropic. So one needs to be aware that endocardial fibrinolysis can also cause this problem. And we lost 2 babies, one of them sudden overnight after diagnosis. Next day, the baby was not there. And this was at 28 weeks, hydrops. So I have already mentioned that before 2020, we were doing this and mechanical PR. And subsequently, we introduced monitoring daily, and we have 13 patients who have completed pregnancies. We have 6 more who are in the process right now and are doing this. 10 patients undertook home daily monitoring of fetal heart rate. 2 patients could not undertake due to geographical reasons. 1 patient could not monitor heart as she found it too difficult to get the baby's rhythm, was on steroids for non-cardiac reasons or non-fetal reasons. She had skin and kidney disease, and no patient developed heart block. Since this started, ectopics, false positives were recorded in 2 patients. We have 25 patients with heart block, 19 patients requiring pacemaker, 16 required at birth, 3 required at a later stage, 1 to 5 years. 6 patients who did not require a pacemaker yet are on follow-up. Some are very young. One of them is 15 years. Her rate's in the 60s. 4 patients required PDA device closure in association. A known association in lupus is patent ductus arteriosus. The antibodies affect the muscle in the ductus arteriosus, and it doesn't tend to close because there's no muscle left. 2 patients required ASD device closure, so the lower rates resulted in a PFO which kept increasing in size. These are also 2 patients who require a pacemaker at a later stage of life. And 1 patient has autism spectrum disorder. 1 patient detected with stroke in early infancy, which the pediatric neurologist has said is due to an intrauterine maternal lupus. And I'll end it there. Thank you very much.
Thank you very much. It appears a reasonably good study. Probably we need to go through that. Did you publish it or just a preliminary
this
data?
is preliminary analysis in the
I guess
process
there will be some artifacts, all those things when analyzing the heart sounds. what do you mean by irregularity of the beating? That's what I don't understand. Is it a 2:1 block, or is just a
No.
ectopy, or how?
Ectopics. So this is one of the findings which you will, as you go through this, you will find out that the ectopics cannot be ignored in lupus babies. Ectopics do indicate, and if there are frequent pauses, they do indicate that this is a compensatory pause due to premature atrial ectopic, and it indicates that the myocardium conduction system is getting affected. And this is something one needs to look at as an indicator of an oncoming complete heart block in the next 24-48 hours.
Any questions, ma'am?
Yes.
Have you found any difference when you started steroids on day one when they detected abnormality versus first week or second week?
I didn't get the question.
So you start steroids if you suspect them having a heart block in a patients with lupus. Now you have all this monitoring system. So do you find any difference day one of missing the things you start the steroids versus somebody you start?
the same day.
No, like have you found a difference when you start on day 1 week or 2 weeks?
No, we started the same day.
No,
Even
no,
yeah, I'm not clear. I'm not able
No,
to-
have you found a difference when you start on day one? Your incidence of heart block is different versus you started after 1 week in some patients because they didn't come to you. So have you found a difference the late you start?
Since we are doing this daily monitoring, they have, yeah, only those who took on and agreed to the protocol. In the previous, before 2020. So, yeah, so before 2020, when we were not doing daily monitoring, we have had 2 patients when we monitored them, they had complete heart block in spite of our monitoring. Yes.
That many of the mothers who develop complete heart block in the babies were never diagnosed to have lupus till we found complete heart
Yes,
block.
it's the first
How?
presentation of lupus.
Yeah, that's the majority. Very few are
Yes.
actually symptomatic.
Yes.
So in the first pregnancy, it's hard to even
Yeah.
manage that.
Yes.
It only happens once they've had a baby,
Yes.
and then you kind of make the
Absolutely.
diagnosis.
So all the heart blocks were primaries. If you saw, I
So-
present all the heart blocks were primaries because
Right.
nobody knows.
No, right.
So there is a movement towards doing an ANA as a routine screening in normal women. There is a movement. The rheumatologists are suggesting that, especially the rheumatologists working in this area to prevent heart
No,
block.
my point is, can we make mechanical PR interval estimation as part of the fetal protocol?
So we'll just diagnose heart block. We won't
Yeah.
prevent it with that.
No, at least you would know if it is increasing, then you would have a,
So this is exactly the conclusion, that it doesn't give you the time, weekly doesn't give you the time to diagnose that.
Thank you. But short of time, I think we'll move on to the next talk, and this time we can have questions.
Just a quick question. In case if we have found fetal heart rate irregularity, like ectopics, in a patient who has got no other background of SLE, should we then, is it worthwhile to ask for ANA like ROLA antibodies?
So this is a very good question, because 18 weeks, a lady comes to you,
Yeah.
sent for irregularity, and you have no background. There may be no other sign of anything. So such patients, you may need to see them more frequently. You may need to see the type of rhythm abnormalities. Just premature atrial ectopics, no. But if you're getting rhythm which you are unable to immediately diagnose, you worry about it, and you're concerned that this is not the routine type of premature atrial contraction, you can get it done. But the problem is the result is not available for 5 days anyways.
Yeah.
So you'd rather see them the next day again and the subsequent day than get a lupus just on the first day.
Thank you.